म्यूट कर क्या? Good morning, everybody. How many of you are here? Let me check. 54. Okay. So let us start. Two sessions we started discussion on chemotherapy. Okay. Then we are having the classification. Then we started discussion on penicillin. And yesterday I finished penicillin family. And because we started with beta-lactam antibiotics, so penicillin is the prototype or major drug from that group. Also cephalosporin. Today I will discuss cephalosporin. So we finished discussion on penicillin in details. Okay. And I also added other beta-lactam antibiotics in that group, smaller ones like carbapenems, monobactams. So till that, we've finished beta-lactam antibiotics, but no, actually we have not finished. Today, we will be discussing another major group of drugs which come under beta-lactam antibiotics, and that is cephalosporins. Okay. So, sorry, I have come far ahead. See, beta-lactam antibiotics having beta-lactam ring in their structure. So 4 different groups of antibiotics are there under beta-lactam. Penicillins, starting with penicillins, then cephalosporins, monobactams, and carbapenems. So in last 3 classes, we have finished discussion on penicillins. We discussed about monobactams. We discussed about carbapenems. So today we will be discussing on cephalosporins. Okay, cephalosporins also a group of drugs. So let us start cephalosporins. So as usual, this also comes under beta-lactam group. Now mechanism of action. Cephalosporins invariably they are semi-synthetic and antibiotics. Okay, and mechanism of action. Mechanism of action, it is similar to that of penicillins. What is that? By inhibiting bacterial cell wall synthesis. Okay, and the process is also very similar to that of penicillin. Okay, so I am not repeating further. Now cephalosporins, let me tell you in the beginning, since it has got a long list of drugs, initially you may find it little difficult to remember the names, but for this you need to read this chapter repeatedly and repeatedly in order to remember the names of the drugs. Okay, because there is a long and it is little confusing also the names, whether it is first generation, second generation, but So many times you need to read that. Okay. Now cephalosporins, they are classified into 4 generations, and a new generation, fifth one is also the fifth one also has come up. Now, what is the basis of that this classification into generations? The basis is none but antibacterial spectrum. Please note, they are classified into generations, 4 generations, based on their antibacterial spectrum, and also to some extent the stability to beta lactamase. Okay, beta lactamase. So this is the actually the stability to beta lactamase starts from 3rd generation onwards. Okay, so these are the basis of classification. Excuse me. Excuse me. So excuse me. So you see that there will be some distinct antibacterial spectra. So let us start the books with the names of the drugs. Mechanism, as I mentioned, same as that of penicillin, so not repeating right now. Now, coming to 1st generation cephalosporins. Okay. Which are the drugs? Cephalothin, cefazolin. Okay. Cephalaxin, cefadroxil. And another drug is there. There are many drugs. The common and a few only I have taken up. Cefradin. Okay. Cephalothin, cefazolin, cefalexin, and cefadroxil. Now, what is the basis? Bring them into 1st generation. The basis is that these 1st generation cephalosporins, they are very effective in gram-positive organisms, but not methicillin-resistant Staph aureus and Enterococci. MRSA and Enterococci. How about gram-negative? Yes, gram-negative also there, but very not that significant, but it is effective. Okay, it is effective, but its effectivity is much less than that of 2nd and 3rd generation. Okay, so I cannot say even moderate, to some extent, little less effect on gram negative. And another basis is sensitivity to beta lactamase. They are very much sensitive to beta lactamase. That's why they are not effective, or they are degraded by beta lactamase enzyme produced by those bacteria. Look at Haemophilus, Enterococci, even Neisseria also. So that's how they are very sensitive to beta lactamase. Now, one more thing before going to 2nd generation, let me mention that why I have written some of the drugs in red and some of the drugs in blue. Is it for decorating the slides? No. It is not for decorating the slide. There is a meaning behind that. And the meaning is those which are written in red font, those which are written in red font, they are administered parenterally. And those which are written in blue font, understand? So that's the reason behind that. Okay. Next, second generation cephalosporins. Let us know the names of the drugs first, like cefoxitin, cefuroxime, cefamandole, cefotetan, loracarbef, then cefaclor, cefuroxime acetyl. Now you are finding two cefuroximes here. One is only cefuroxime acetyl. So as usual, the red font drugs are given or administered parenterally, and the blue ones, they are administered orally. As I mentioned, there are two cefuroxime. One is given parenterally, and cefuroxime acetyl is administered orally. And cefuroxime acetyl is a prodrug of cefuroxime. The one which is given orally is a prodrug of cefuroxime. Is that clear? Okay. You can see two asterisks in cefoxitin and cefotetan. Okay, two asterisk marks are there. Why? At the end, I will explain why these two asterisks are there. Please try to remember that. Okay. Now coming to the basis of its classification or its antibacterial spectrum. The basis is first antibacterial spectrum, and the second is sensitivity to beta-lactamase. So antibacterial spectrum for second generation, the antibacterial spectrum is they are effective, they are actually more effective against gram-negative microorganisms compared to first generation. And also they are effective against anaerobes, but their effectivity against gram-positive is less than that of first generation. So first generation gram-positive 3 more of gram-negative and less of gram-positive. But second generation, though it is more with gram-negative, but it is not effective against Pseudomonas. And second generation, to some extent, they are stable with beta-lactamase. That's how they are one step ahead. Okay? How? With gram negativity and stable with beta-lactamase, or they are resistant to beta-lactamase. Okay. But they are not effective against Pseudomonas. Next, third generation cephalosporins. Third generation, there are many drugs, cefotaxime, ceftriaxone, cefoperazone, ceftazidime. Okay, so like that, there are many drugs which are all given parenterally. And orally, cefixime, cefpodoxime proxetil. Okay, and there are other drugs also, but they are the commonly used drugs. Now coming to their antibacterial spectrum. Now compared to first generation, their antibacterial spectrum is little higher side. They are also effective against first gram-positive, but added with enterococci. Whereas first generation, you see, they are highly effective against other gram-positive, but not with MRSA and enterococci. Whereas third generation, they are effective against gram-positive added with enterococci. And they are more effective with gram-negative as well. So you see, in this way, their spectrum is getting widened. And some of the pseudo, what is that called? Pseudomonas. Okay. So from here, pseudomonas sensitivity is started. Till second generation, pseudomonas totally resistant. Third generation onwards, yes, to some extent, pseudomonas is started. And they are also resistant to beta-lactamase. They are also resistant to beta-lactamase. Okay. Coming to fourth generation, the drugs are cefepime and cefpirone, and both are given orally. Parenterally. Cefepime and cefpirone both are given parenterally. How about their spectrum? Their spectrum is more than that of third generation, similar to third generation, but added with pseudomonas, which is highly effective. Okay. I said for third generation pseudomonas, yes, they are effective, but very quickly they get resistant also. But fourth generation, highly effective against pseudomonas and gram-negative as well. They are more resistant to beta-lactamase. They are more resistant to beta-lactamase. Then coming to fifth generation, okay, the drugs are ceftaroline and ceftobiprole. Okay, ceftaroline and ceftobiprole. See, initially you may find it little difficult to remember the names of the drugs. Okay, so what is the solution for that? Often I come across the students, madam, drugs का नाम याद ही नहीं रहता. True, it is difficult. It is not that easy. But you have to remember the names of the drugs, because finally it is you who have to prescribe those drugs. If you cannot remember, how can you prescribe the names of the drugs? Finally, यही तो तुम्हारी keys है, ना, in future. So what is the solution? अभी ही time है during student life कि repeatedly and repeatedly you need to study. Another tips which I can give you is make charts of your own. ऐसा नहीं है कि वो नेट से कॉपी पेस्ट करके उसका प्रिंट आउट लेके अपने वो जो क्या कहते हैं, क्या बोर्ड, पिन बोर्ड, जो स्टडी टेबल के ऊपर जो रहता है वहां पे पिन अप कर दो. नो, यू राइट योरसेल्फ. सो उसमें फायदा ये होता है, many of you make mistakes in spellings of the drugs. तो अगर खुद एक बार लिख लो ना, तो वो स्पेलिंग मिस्टेक्स का चांसेस कम होता है. और वही तुम्हारी राइटिंग तुम बार बार देखोगे, पढ़ने की जरूरत नहीं, सबकॉन्शियस माइंड में आंख उधर जाने वाले ही है. सो यू विल सी, इसलिए तुम्हारी ब्रेन में वो सब रजिस्टर्ड हो जाए. So this is the what can I say, guidance I can give you, how to remember the names of the drugs. इसके साथ तो निमोनिक्स वगैरह है ही. Mnemonics are only there for your exam purpose, but for long term retention of the names of the drugs, this is a way out. Make your own charts. You write. देखो, ऑनलाइन क्लासेस का ये भी और एक प्रॉब्लम है. फिजिकल में हम लोग जितना फिजिकल प्रेजेंस में समझा सकते हैं, वैसा ऑनलाइन में फॉर मी तो इट इज डिफिकल्ट टू रीच यू ऑल. ओके, सो सिमिलरली फिजिकली खुद जब करोगे ना, तब उतना याद रहता है. सो यू राइट स्पेशली फॉर दिस चैप्टर of beta lactam, or this chapter of chemotherapy. एकदम मतलब वेरी कंफ्यूजिंग, इसीलिए बार बार पढ़ना पड़ता है. सो इंस्टेड ऑफ गिविंग डेडिकेटेड टाइम, give some time to prepare charts, paste it on your pin boards, स्टडी टेबल के ऊपर, या तो दीवार पे या तो दरवाजे पे, जहां पे तुम लोग रेगुलर तुम्हारे ये है. एंड so that you will see the names of the drugs and write your own, prepare your charts own. No cut and paste from the computer. This is for avoiding the spelling mistakes of the drugs, because I reduce mark if there is spelling mistake of the drug. Okay, I cut marks. कोई सवाल ही नहीं उठते, because if you do not spell it rightly, ब्रांड नेम में कोई और ड्रग आने वाले हैं जिसमें वो स्पेलिंग है, and you are prescribing wrongly then. Understand? So that's why spelling is important. Fine. So carry home message from this is you need to, यहाँ पे mugging के भी जरूरत है. I agree. You need to mug up the names of the drugs. I agree with that. And especially first generation में कौन सी, second generation, third generation, fourth generation, it is very confusing. And for your MCQ, these are the drugs. Even for your, I don't know, you will be perhaps facing next exam and all, but definitely there will be some MCQ test in your for your internal and all those things. And these are the very tricky names of the drugs. Which of the following drugs belong to second generation cephalosporins? If you do not know the names of the drugs, how can you answer? So for that, I am emphasizing here. Okay, fine. Next, points to note. Now, there are certain important points from this chapter which you should not forget. Okay. First, second, third, anti-pseudomonal and anti-MRSA. These are the final generations. In other words, first generation, more gram positive, less gram negative. Second generation, more gram negative, less gram positive. Third generation, almost 50-50. included Pseudomonas. Fourth generation anti-Pseudomonal. And fifth generation anti-MRSA. Can you see? Am I right? Yes. Okay. So in this way, first remember this. First generation, I am repeating, first generation, more of gram positive, less gram negative. Second generation, more of gram negative, less of gram positive. Third generation, almost 50-50. First gram positive as well as gram negative included there. Third generation, how it is senior or higher than first and second, anti-pseudomonal as well. But third generation, very quickly they get resistant to anti-pseudomonal. Then fourth generation dedicated to Pseudomonas, anti-Pseudomonal. They do have other property, but we do not use them for others. We use them only for Pseudomonas. And fifth generation anti-MRSA. Tip. Okay. Other than that, now next question is, which are the anti-Pseudomonal cephalosporins? Anti-Pseudomonal. Okay. Fourth generation, you know, cefpirone and cefepime and cefpirone. These two are there. These two. Fourth generation. But from third generation, the most effective anti-pseudomonal is ceftazidime. Just remember that. Not all are anti-pseudomonal. There is a question. So we can say that we go further in generation, there is increased coverage of gram-negative bacteria. Gram-negative, yes. Second generation is maximally gram-negative. Third generation also, yes. But third generation almost equally with the gram-positive. Mind that. Fourth and fifth, see, anti-MRSA, Staph aureus, is gram-positive, but this is most notorious one, which is resistant to methicillin. That's why this fifth one, anti-MRSA, it is for gram-positive cocci, but this is mainly specifically for methicillin-resistant Staph aureus, whereas fourth generation is mainly for, we have kept it reserved for what? Pseudomonas. Okay. You are right, but not fully, I can say you are right. Okay. Yes. Then anti-MRSA, cephalosporin, that is fifth generation. Okay. Ceftobiprole and ceftaroline. These tips are very, very important for you, for your Viva, for your MCQ, for your future practice. Okay. Then, none of the cephalosporins have got reliable activity against certain bacteria, like Enterococcus, another very cumbersome bacteria, which cumbersome means unruly bacteria. There are certain unruly students in the class, जिनको control नहीं करता. So Enterococcus is one of them. Legionella, another. Then Clostridia difficile are there, Campylobacter jejuni, etc. etc. There are certain जल्दी मतलब control में नहीं आते. So that is the thing. Next slide. Uses. Okay. I have written here in short. You may elaborate it as per your textbook. Okay. In short, I have mentioned it here. Okay. Now, first generation cephalosporin, again I repeat, gram positive, more of gram positive, less of gram negative. So still they are used, and now they are mainly kept for prophylaxis for surgical prophylaxis. Okay, surgical prophylaxis, and the drug which is given is cefazolin from the first generation. It is meant for mostly surgical prophylaxis, and the drug of choice for surgical prophylaxis is cefazolin from first generation. Okay. Second generation, you can see there are certain oral preparations like cefuroxime, cefotetan, cefoxitin, etc. And they are used for respiratory tract infections and others for peritonitis and pelvic inflammatory diseases. Pelvic inflammatory diseases are the causative organisms are mainly gram-negative organisms. Cefuroxime, cefotetan, cefamandole, they are kept for that. Fine. Then third generation cephalosporins, the most commonly used drug is ceftriaxone. Okay, ceftriaxone is the most commonly used drug, and it is used in various conditions. So sometimes in nosocomial infection, in what can I say, in gonorrhea, I have mentioned it, in Lyme disease. Okay, so ceftriaxone is used in gonorrhea, in Lyme disease, cefotaxime, and also ceftriaxone is used in meningitis. Meningitis in non-immunocompromised patient and in community-acquired pneumonia. In community-acquired pneumonia, these drugs are used. Okay. Also in nosocomial infection, that means in hospital-acquired infection. Fine? Okay. This is in short, actually, I have written the most important uses of cephalosporins. You can elaborate that in the book. There is a long list like urinary tract infections, meningitis separately, mixed aerobic, anaerobic infections. Okay. Also in typhoid, ceftriaxone in typhoid, alternative to ciprofloxacin. Okay. So like that, you will get a long list in the book. Then coming to adverse drug reactions. It is important for you, adverse drug reactions. There are certain allergic reactions. Okay, allergic reactions, these can be local reactions, these can be systemic as well, like skin rashes and all. Other than that, fever, serum sickness, etc. are there. Yes. Another thing, how it differs from penicillin is that in penicillin G, can you remember I mentioned of anaphylaxis? Though less, but if occurs, it becomes a severe reaction. This is rare with cephalosporins. So that's why nowadays many physicians and doctors, they prefer cephalosporin instead of penicillin because of this limitation. Okay. But it is also seen that for allergic reaction, the patients who are show cross-reactivity to cephalosporins also, though the percentage of patients in that will less, maybe 20 to 30%, but there is a chance of cross reactivity to cephalosporins. Okay, then mind that one more thing, when you will be starting reading these various drugs now, finally when you cannot remember anything for any drug and every drug, the students write nausea, vomiting, diarrhea. Okay, please avoid this this time, I must tell you. Okay, so there is no nausea, vomiting here in that way. But yes, diarrhea can be there by some of the cephalosporins because some of them are excreted through bile. Okay, and because of that, they cause diarrhea. And most common with cefoperazone. Remember that. Not all cephalosporins cause diarrhea, but definitely with cefoperazone. Okay. This ceftriaxone is a very commonly used cephalosporin. Okay. But ceftriaxone, one problem with ceftriaxone is that it can cause biliary pseudolithiasis, biliary stone, but it is pseudo, it is not actually stone formation. Okay. Then nephrotoxicity. Mild nephrotoxicity is noted with some of the cephalosporins, but that is dose related. Okay. And out of all these cephalosporins, cephaloridin is the one which causes, which has got the more chances of nephrotoxicity, but often it is dose related. Okay. Now coming to another very important point of hematological adverse drug reactions. Hematological adverse drug reactions reflects in there is a tendency of bleeding, and this bleeding is due to hypoprothrombemia. Hypoprothrombemia, that means prothrombin level goes down, and this is caused by moxalactam, cefoperazone, cefotetan, and cefomandel. Where do they stay? Where are they standing? Let me go back. Cefotetan, cefoxetine. Okay. I think I haven't mentioned moxalactam here anyway. Cefamandel. So you can see them. Fine. Why? And you can also see cefotetan, cefoxetine, this asterisk. Here comes. This asterisk is why I have mentioned to relate this. Why others are not causing hypoprothrombemia and why these drugs, they are causing this bleeding, and this bleeding is due to hypoprothrombemia. Why? Because they contain one group, one in their structure, which is known as MTT group. MTT stands for methyl, M is methyl, first T is thio, and the second T is tetrazole. So it is MTT stands for methyl triotetrazole. This structure is there in some of the cephalosporins like this, what I have mentioned here, cefoperazone, cefotetan, okay, cefamandel, And this is the reason to cause hypoprothrombinaemia leading to bleeding. Okay. And this can be, of course, prevented by concurrent administration of vitamin K. Okay. If for some reason, if you are to prescribe this drug, also prescribe vitamin K along with that, so that prothrombin level will come up. Fine. Then there is disulfiram-like reaction if some of the cephalosporins are given along with alcohol. Okay. Disulfiram-like, please note this term. When we will discuss in CNS alcohol, definitely this term will come, and there we will explain and discuss in details. Disulfiram-like reaction is somewhat, disulfiram actually is a drug. If it is given along with alcohol, it causes severe effects like severe abdominal pain, vomiting, sweating, excessive sweating. The patient becomes restless and very, what can I say, awkward situation, very uncomfortable situation for the patient if disulfiram is given along with alcohol. And this disulfiram is the one drug which is given, why, you know, for de-addiction of alcohol. This disulfiram is used for de-addiction of alcohol. Fine. In de-addiction program, you will see that even today also there are other drugs as well, but disulfiram was the first identified one for de-addicting alcohol. Fine. So patient needs to understand that because he took alcohol, that's why he develops such symptoms, and then slowly he leaves that, he gets de-addicted. That's how the name disulfiram-like reaction has come. Now, there are certain cephalosporins also, which instead of disulfiram, I'm telling, when they are given similarly like disulfiram, when they are given with alcohol, they develop similar symptoms: abdominal pain, vomiting, sweating, restlessness, etc. So that's how they are known as disulfiram-like reaction. And these are the same cephalosporins mentioned above: moxalactam, cefoperazone, cefotetan, cefamandole. Because again, because of that structure, okay, MTT structure, they cause these type of reactions with alcohol, okay, along with alcohol. So adverse reaction is disulfiram-like reaction. Superinfection, right now I will not, I will be continuing with chemotherapy at the end. Today we are not discussing superinfection. Why? Because you need to understand the broad spectrum antibiotics as well.